Ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone and welcome to the last day for virtual endocrine diabetes and obesity Congress 2020. My name is Dr. Muntasir, adult endocrinologist, National Guard Hospital, Dammam. It is my honor to chair this session and would like to thank the scientific committee for this opportunity. Today we have four great speakers. I hope you will enjoy. Without any further ado, it's my pleasure to introduce the first speaker. She's our colleague, Dr. Reem Al-Amoudi. She's a consultant in endocrinology, metabolism, and diabetes. King Abdulaziz Medical City, National Guard Hospital, Jeddah. She is very active in research. So Dr. Reem, she's going to, for the next 20 minutes, she's going to updating us about the diagnosis and treatment, therapeutic challenging in non-alcoholic fatty liver and non-alcoholic steatohepatitis. So it is very hot topic. We know it is underestimated or underdiagnosis. So, Dr. Al-Amoudi, you are welcome and your control.
Thank you very much. Let me just share the screen first.
Yes, okay.
Okay. Thank you very much, Dr. Muntasir, and thank you for all the VEDOC team. It's been a tremendous pleasure to be among this cast, and it's really great efforts by the Saudi Diabetes and Obesity Society. So the topic given to me was to talk about the diagnostic and therapeutic challenges in NASH or steatohepatitis. These are my disclosures. And as Dr. Muntasir mentioned, it has been a hot topic lately after years of being underestimated or unrecognized. And just this month, I don't know if everybody knows, but we celebrated the third International NASH Day, raising awareness about this topic. So the outline of my topic is going to be very simple. 3 points. Why do we care? What are the challenges that we have in the diagnosis? And what are the challenges that we have in management? Starting with why do we care? As we mentioned, it's highly prevalent in the Middle East. It's one of the most prevalent areas with NAFLD, up to 32%. And just looking at this map, you could easily recognize that it easily fits or goes side and side with what we see in the epidemic of obesity and diabetes. Wherever you find these two risk factors, you will find NAFLD. And lately, over the last, let's say, 10, 15 years, it has jumped more than 3 times, more than triple, in being the leading etiology of a liver disease needing a liver transplant. Just looking at this slide, you can see compared to other causes needing a liver transplant that have only maybe risen by 15 to 40%, NASH has risen 170%. And data from Saudi Arabia projected up to 2030, again, go with the same view, showing that we are expecting more and more increases in liver-related death and hepatocellular carcinoma related to NAFLD. So what is NAFLD? NAFLD is basically a spectrum of diseases that starts with a simple steatosis defined as more than 5% of fatty infiltration in the liver that can progress up to liver cirrhosis. And the natural progression, generally in a healthy liver, the chance of it transforming into steatosis is about 25%. This would increase in patients who have higher risks, such as obesity or type 2 diabetes, up to 75%. And out of those, 70% will remain in the benign stage of only steatosis or benign infiltration, but 10 to 30% will progress to a steatohepatitis stage, whether with or without fibrosis. Up to this stage, it's still very reversible, and if the risk factors are controlled, the patients can go back to the healthy status. However, about 2% of those who develop fibrosis will go into developing cirrhosis. And once cirrhosis is developed, there's a 1 to 4% per year chance of developing hepatocellular carcinoma and a 50% chance of death or needing a liver transplant. And the problem is not only related to the liver, but this disease also affects other organs, and the main one being cardiovascular disease. So actually, cardiovascular death is the leading cause of death in these patients. And the issue of mortality or overall mortality is very related to fibrosis. The higher the degree of the fibrosis, the higher the mortality. So fibrosis is important and it matters and it should be prevented. But the good news is that it really does take a long time for it to develop. So if we look at patients who are still between stage 0 and stage 2, it's been 20 to more than 30 years of time for it to develop into cirrhosis or decompensated liver disease. While for those who are in stage 4 and 3, it might take less than that. So the message here is that there's plenty of time for us to look for it and screen for it and prevent it. So now let's move on to what are the challenges that we face in diagnosing NAFLD and managing this disease. Starting off with the pathophysiology. Really, up to now, I mean, we understand probably most of it, but there's a lot of it that is still not fully understood. So it's not just a matter of fatty infiltration. We know that that's the main thing that happens, the insulin resistance, the adipose tissue inflammation, and the increased triglyceride synthesis and lipotoxic agents that cause this fatty infiltration. But then what causes it to develop into a steatohepatitis? What causes the oxidative stress? What activates the inflammatory pathways of the Kupffer cells? What causes the apoptosis of the liver cells? And what causes the fibrosis? So many elements involved that still need to be more explored. And you could see that in, I would say in a nutshell, it starts with this imbalance between the lipogenesis and the oxidation and the VLDL secretion, but then you still need a second, a third, or a fourth hit for it to develop into NASH. And that's why management of the disease can be a bit complex, needing more than one type of agent to address all these pathophysiologies. And the second most important challenge is what we mentioned in the beginning, that is really underestimated and underdiagnosed, and it is not always routinely screened for. So in this study that looked into patients presenting with cirrhosis, 74% of the time, the diagnosis of NAFLD was an incidental finding at the time that the patient already had cirrhosis. So how do we diagnose this disease? I mean, basically the diagnosis list goes from understanding who is at risk and who should be screened, ruling out other causes that can cause elevated liver enzymes, ordering liver enzymes, looking for steatosis by ultrasound, and then assessing for the fibrosis. But in each and every one of these, we do have some challenges, starting with patients at risk. So we all agree that patients who are obese or have diabetes or metabolic syndrome are at high risk. However, guidelines still don't clearly state how and when and should we screen them. The cost effectiveness of strategies of screening are always questioned. However, lately, the European Association for the Study of Liver Disease did recommend that both ALT and liver ultrasound should be done in patients with high risk. And then coming to the ALT and the liver ultrasound. So again, what defines a high ALT? What's the cutoff? Should we go with the lab reference or should we go with a standard cutoff? Many hepatologists agree that it should be a standard cutoff that is gender related, so more than 19 in females or more than 30 in males. And any elevation should be abnormal. We shouldn't be saying it has to be double or triple the higher level of normal. And then we come to the challenges we face with ultrasound. The sensitivity is limited. You need a little bit more than 20% for it to show. The high echogenicity that you see in ultrasound is not specific to steatosis. It can be caused by fibrosis or infiltrative diseases. However, in addition to ALT, it is very useful as a screening method for patients at high risk looking for steatosis or NAFLD. So moving on is the issue of confirming the disease before starting treatment. And here comes the requirement or not for liver biopsy. Now, historically, liver biopsy has been the most important test. It's considered the gold standard. It's the only way in which you can really define or show the difference. Is it only steatosis, or is there an element of steatohepatitis and fibrosis? However, it does have a lot of limitations, being an invasive procedure with potential serious complications ranging from bleeding to pneumothorax to even death. It does need a specialized interpretation associated with a lot of observer variability, and it's not always feasible. So generally impractical and not always available for all patients. So do we have an alternative? Yes, we do. And lately, there's been a lot of work in developing what is called non-invasive testing to assess this level of fibrosis. And these tests range from simple scores that anybody can do in the clinic to proprietary predictive scores, which are patented to certain kits, like the FibroSure and the ALF, and they're not always available everywhere. So these are basically a group of tests done together, and they give you a score, and they're patented to certain companies. And then we have the imaging. So let's talk about the simple scores. Simple scores, as I said, very easy. Anyone can do them. The FIB4 is the easiest to calculate. It's basically age times the AST divided by the platelets times ALT. Even if you don't want to calculate them, they're available in many medical apps. And they have really high predictive value, both negative and positive. So if it's less than 1.4, 90% negative predictive value. If it's more than 3.2, it's 97% positive predictive value. Another score that can be used is the NFS, or NAFLD fibrosis score. It's a little bit more complex calculation, again, associated with a certain score that's associated with even the degree of the fibrosis from 2 to 4. And then for those who do turn out to have a high score by calculation, usually they are referred for more a better way of assessing it through imaging. And one of the commonest that are used by many hepatologists is the FibroScan, or transient elastography. And this is basically an ultrasonic machine that measures the stiffness of the liver. And the higher the cap value that they get, the more stiff. And it has been validated against liver biopsy. And according to the score that you get, you could grade the fibrosis expected in that patient. And another imaging that's also commonly used and has been really well validated is MRI, or MRE. So it's basically an MR elastography, and again, associated with very nice scores that have been validated again against the degree of fibrosis. However, being an MRI makes it expensive and probably not readily available for many people. So generally, if we want to put the diagnostic strategy, is number one, screen patients who are at risk with ALT and ultrasound. So here you're identifying presence or absence of steatosis. If they do have steatosis, then this is the first stage of NAFLD. Now you move on to assessing the degree of fibrosis or NASH. And we'll put it in a little bit more detailed algorithm. So what a diabetologist or a GP or a family doctor would do, he's the first line to see the patient, ruling out other causes, thinking if he is at risk, and calculating the FIB scores for those who do have higher, presence of steatosis by ultrasound and high ALTs. Now, if this FIB score is low, patients are advised only that this is a low risk, so lifestyle modification, you don't need to do anything more. If the FIB score is high, then this is the time that they are at risk of developing fibrosis, so they should be referred to the hepatologist. Now, the hepatologist is usually the one who would be ruling in presence or absence of advanced fibrosis through transient elastography or FibroScans, and if done and the scores are low, so the patient is at low risk for having advanced fibrosis, again, attempt lifestyle and maybe consider repeating this test in a year. And if the scores are high, then they might consider biopsy depending on the situation, and treatment should be indicated. So we finished the part about the challenges that we have about diagnosing this disease, but then we come, so if we do, can we manage it? And what are the challenges that we have and what's available for us? So the bad news is, until up to now, we really do not have a single agent that has an FDA license for NASH or for NAFLD. And looking at the spectrum again, we have the three elements that we talked about. We have the metabolic part, and we have the inflammatory part, we have the fibrosis, and each of these elements have a lot of agents that are dedicated towards reversing them. However, so far, the main management supported by guidelines have focused on improving insulin resistance through lifestyle modifications and pharmacotherapy that assists insulin resistance. Weight loss has shown consistently in almost every single study that is associated with resolution and improvement. And in this study that had more than 10% weight loss, it was associated with not 80 to 100% improvement or resolution for even advanced stages. But however, 10% weight loss is not always practical. So even those who managed to lose 5%, again, did manage to show quite significant improvement. And this has also been shown in the bariatric surgery studies that shows 85% resolution of NASH in patients who had it before the surgery, with the other 15% showing significant improvement. And this has also been shown in biopsy study. Now, exercise does influence liver fat in a way that it's independent of the weight loss through the de novo lipogenesis. However, the physical activity studies have not been as good or as strong as the weight loss studies. So the summary of what the guidelines say about in lifestyle: weight loss, 7 to 10% with any diet that works. They do recommend in some situations the Mediterranean diet. They have some questionable recommendations regarding caffeine intake, and alcohol should be avoided. And they do recommend exercise at least 30 minutes of moderate intensity 3 to 5 times a week. Moving on to the pharmacotherapy. So you could see here the tremendous pharmacological company run over the last decade, just for, they're all going after one goal. They want to be the company that produces the first licensed medication, looking at so many different pathways from fibrotic to inflammatory to metabolic. These are generally the different pathways that has been or studied, or we have medications that have been, whether in phase 1 or 2 or 3. So the fat deposition or metabolic stress, the insulin sensitizers, we have the PPAR agonists with the PPAR alpha, or the combined ones. And out of them, pioglitazone remains to be the one with the consistent results. We also have recent studies on GLP-1s and SGLT2 inhibitors. Again, they act through improving insulin sensitivity in addition to some anti-inflammatory effect and reducing the lipid deposition in the liver. We have the FXR agonist. Obeticholic acid has, again, good results, has already reached phase 3, and it basically negatively upregulates the bile acid pathway. We have other bile acid sequestered medications. We have that only working on absorbing fat, microbiota. And then we have immunomodulators acting on the inflammatory processes or the apoptosis. And we have so many other processes like the vitamin E and the thyroid hormone receptor selective agonists that act on the oxidative stress, reducing the injury. And lately, we also have some specific agents that address the fibrosis, which are the FGF21 inhibitors. Now, out of these, some of which have reached phase 2 and 3 trials, again, you could see from the p-values, it seems that pioglitazone and liraglutide seem to be the most significant, followed by obeticholic acid when it comes to resolution of NASH without worsening of fibrosis. And for those that have showed reversal of fibrosis, again, we have obeticholic acid already in phase 3 and showing really good results, and followed by Sensorok, which is an anti-inflammatory. So having said that, what do the guidelines support? So far, the guidelines support drugs that with proven NASH resolution and at the same time that have cardiovascular risk reduction, because as we said earlier, that this is the major cause of death in these patients. And you find pioglitazone supported by most of the guidelines and GLP-1s by some of them, specifically the endocrine guidelines. I don't know, how much time do I have left?
Dr. Reem, 3 minutes left, please.
3 minutes, okay. So I'm just going to pass quickly over. So these are some of the studies on the pioglitazone. So even in patients without diabetes, it's had shown tremendous effect. In addition to vitamin E, liraglutide in the LEAN study, but it was a small one, 52 patients. But again, it showed really good results. And we have also some studies on SGLT2s and NASH that have showed resolution of inflammation, steatosis, and fibrosis. Out of all these, again, as you can see, pioglitazone is the one that stands out as the most consistent and significant. And that's why the latest guidelines from the American Association for the Study of Liver Disease recommend pioglitazone in patients with or without diabetes and vitamin E in patients without diabetes. And they think that GLP-1 is still premature to consider them, and they do not recommend metformin. So lastly, just to touch on that, there's so many other challenges that we still have to be thinking about, even if we develop the medication that can treat this disease. How would we monitor the response? Do we do liver biopsies? Do we depend on the non-invasive testing? How should we escalate or modify the treatment if there's no response? And there are some authors who have suggested certain pathways, but again, we still need more data before this can be clinically applied. And this is my last slide, that probably the future would be more even towards combination therapy, because as we mentioned, the pathophysiology is complex. We need to address the weight loss, the insulin sensitization, the lipid reduction, the cardiovascular protection, in addition to the anti-inflammatory or antifibrotic in the event that these are an issues. And probably using combination therapy would increase the response rate and maximize the response and maybe even improve tolerability. With that, I come to my conclusions. So I think I've shown you how NAFLD is highly prevalent and associated with really high mortalities and morbidities. Its pathophysiology is heterogeneous and not really completely understood. And this is what has halted the development of the right agent. The key challenge is always early identification of advanced fibrosis and treating it as early as can before it progresses. The non-invasive testing seems to slowly replace liver biopsy. Weight loss remains the core modality of therapy. We still do not have a licensed therapy. However, pioglitazone and vitamin E are in the guidelines, and there's still a very high unmet need for an effective treatment that can halt the progression in this disease and prevent liver cirrhosis. And with that, thank you very much.
Thank you very much, Dr. Al-Amoudi. And so thank you very much for a very informative presentation and sticking in your time. The question will be at the end of the session. It is my pleasure and honor to introduce the second speaker. Actually, we are more happy when we see some subspecialty, other subspecialties that endocrine to share with us in our Congress. And this is great, actually, and thank you very much for coming. The second speaker, Dr. Abdullah Qashqari. Dr. Abdullah, he has subspecialty. He has a transplant nephrologist, assistant professor at King Abdulaziz University Hospital, and also he's a consultant for Divita KSA, I don't know what's it, and act as their strategic initiative director, and also he's a fellow of the Royal College of Physicians, Surgeons in Canada since 2002. Dr. Abdullah is going to talk to us very common problem, and usually it need multidisciplinary joint clinic. Diabetes kidney disease is going to talk about the problem and solution. Thank you, Dr. Abdullah, for coming, and you are very welcome. Take the control, please.
Thank you very much, Dr. Muntasir, for this introduction, and thank you for inviting me in this great conference as well. So I'm just going to share my screen. Where did it go? Yes, here we go. Okay.
Dr. Abdullah, can you put in the view?
Yes, so is that now?
Okay, it's good. Yes, go ahead.
Okay, so today we're going to talk about the diabetic nephropathy. It is a very long topic, and it has a lot of things to talk about, but I'm trying to outline these things in the presentation. The first one is the prevalence and natural history, trying to touch on the clinical feature and screening, and progression and the outcomes, and what are the strategies for preventing progressive nephropathy, and how to modify the diabetes medications as the GFR declines. You know, it's a lot of things to try to cover, but we'll do our best. So I'm going to start with this general question. Most of the patients with diabetes and CKD will die without reaching the need for dialysis or kidney transplantation. So that's just a question, is it true or false? And the answer is actually true. So majority of patients with diabetic nephropathy will not reach the level of dialysis or kidney transplantation. It's about only 10% that actually reach that stage. And then 90%, so the majority of patients with diabetic nephropathy, if they're gonna die, they will die from chronic vascular disease or infections. And here you can see the incidence of end-stage renal disease and the prevalence rates by the primary diagnosis in the USA. The yellow line is the diabetes, and the blue line here at the end is the cystic kidney disease. And you can see the prevalence and the incidence is usually associated, it is higher in diabetes patients. And even if you go to the prevalence, it's the same. Diabetes compromising the majority of the dialysis patients. And this diagram here shows that half of the patients on dialysis, they're actually diabetics. A quarter of them are hypertensive, and the other quarter is other diagnoses. So if you're going to look into how the diabetic nephropathy progress over and develop over time, let me walk you through this slide. So the stages of the chronic kidney disease are in the top line here: stage 1, 2, 3, and 4, and these are the number of years involved, and then the number or percentage of diabetic patients. Majority of patients actually, they have what we call functional changes in the kidney function, and that is in the stage 1. That means there's a transient microalbuminemia and occasional hypertension, probably not in type 1, but in type 2. And then there's kidney hypertrophy. But once you go over the stages and the disease progresses, there start to be some more structural changes in the kidney, and those structural changes could be the microalbuminuria will be fixed, and there is a glomerular basement membrane thickening, so there is a structural problem, and then the proteinuria progresses over time until it reaches the nephrotic range of proteinuria at the stage number 4 and 5. So here, I'm going to talk about all these stages. So the onset of diabetes, and then the structural changes, and then the later stages of the kidney disease in the following slides. So I'm going to start with this onset of diabetes type 2, which is what we call the functional changes in the kidney, whether it's in the size or in the GFR. So this is this study that shows that if you go into the healthy non-obese volunteers, the GFR ranges or averages about 115 ml per minute per 1.7 meter squared surface body area. But if the patient developed a diabetes or newly diagnosed diabetes type 2 specifically, you can see the GFR is actually way higher, and that is an indication there's a functional changes in the kidney when it comes or when the patient developed diabetes. And even if you compare that in obese patient, which you know obesity does have that change in the kidney with hyperfiltration, but still newly diagnosed diabetics have higher GFR. Now, if you go to the early stages of nephropathy, when there is structural changes in the kidney, and mesangial expansion, microvascular changes, and the microalbuminuria and high blood pressure, so there are different things that are changes in the kidney. And here in this slide, it compares type 1 and type 2 diabetes when it comes to proteinuria, the prevalence of proteinuria. You can see it is higher in type 2 diabetics, especially if you go more with years, and even this change is actually, it's more prevalent, and it depends on the type of diabetes and the duration of the disease of those specific patients, which I can explain in the next slide. So if you're going to look into the ADA recommendation in the screening for microalbuminuria in all type 2 diabetics at the time of diagnosis of diabetes, because usually it is a little bit delayed, and most of the patients develop the proteinuria early on in their disease. Whereas in type 1, the screening of microalbuminuria usually is at 5 years after the diagnosis of type 1 diabetes. So what's the point with the microalbuminuria? What's the deal with it? Now, the evidence shows that the higher the microalbuminuria, the higher risk of death on those patients. And that is associated with a lot of cardiovascular disease and renal involvement. You can see that the risk goes higher the more the urinary concentration of protein. So that's another a study that shows that the higher proteinuria, you have the survival rate of cardiovascular mortality actually go higher. And even in the events of the cardiovascular events, it's actually way higher in patients with higher proteinuria, which is the blue column here. And even in stroke, it's higher in those patients compared to the lower group of proteinuria in the red column. Here you go. Is this reversible? It is reversible, and specifically, and it comes in type 1 diabetes. And I think the reason for that is it's caught on early on in the disease. And you can see in this 2 years follow-up study that patients who are monitor or control their diabetes and put on the right treatment, the percent of patients with normal albumin excretion actually goes higher at the end of the follow-up time. So more about proteinuria and raising creatinine we're going to talk about, and that goes in the 10 to 20 years of onset of the diabetes. So the clinical features of diabetic nephropathy usually is the proteinuria, reduced glomerular filtration rate, and renal diabetic pathological changes, and the GBM thickness and arterial hyalinization increase in ECM, as well as the nodular glomerulosclerosis. All these are structural changes in the kidneys. So this is more kind of pathological things and histology of the diabetic nephropathy, whether mesangial expansion or there's the nodules in the glomeruli and the arterial hyalinosis in the kidneys as well. So if you go over this question, which of the following patient is least likely to have diabetic nephropathy? Whether it's a type 1 diabetic for more than 15 years with retinopathy, or type 1 for 15 years without retinopathy, or type 2 15 years without retinopathy, or type 2 for 3 years of retinopathy. But you can see the least likely, we're going to answer that in another slide. So the diagnosis of over diabetic nephropathy, usually proteinuria in appropriate time frame, which is usually somewhere about 17 plus minus 6 years in patient with type 1 diabetes. And then presence of retinopathy is in almost certain in patients with type 1, but only 2/3 of type 2 diabetes have retinopathy. We always have to rule out other causes of nephrotic syndrome. And I get this a lot in my clinic when a patient comes with a nephrotic syndrome and renal insufficiency and they're diabetic, and the question comes whether this is actually diabetic nephropathy or not. There's a lot of things we look at, but diabetic nephropathy could be the presentation. And there's a study that looked into retrospective biopsy series, and they found about only 1/3 of patients that have actually diabetic nephropathy, but in prospective biopsy series, only 5% had diabetic nephropathy with an overt nephrotic range proteinuria. So now the answer is obvious. The type 1 diabetes for 15 years without retinopathy, that will make it least likely, as those patients usually 90 to 95% would have retinopathy associated with the nephropathy. What about end-stage renal failure? Now, in the outcomes of diabetic end-stage renal disease, patients with diabetes have a worse prognosis for survival than end-stage renal disease patient without diabetes. And that is associated with increased cardiovascular disease, largely accounts for this high risk in this particular group of patients. Now, the survival improves significantly with living-related donors transplantation compared to dialysis. Unfortunately, just the Dr. Moody mentioned earlier, there is no specific treatment for this, just like the NASH. There isn't a specific treatment that I can give the patient to treat the diabetic nephropathy. And I get that a lot at the clinic when they ask me what I can do. It's like, there's nothing that I can do for you, but what we can do is try to prevent the progression of the disease as much as we can. And the points that we focus on the clinic is, one, the glycemic control, two, lipid lowering measures, quitting smoking and weight loss, blood pressure control, and the use of the inhibition of RAS. Now, since the glycemic control is one of the measures that we will talk about and is very important in preventing the progression, the question always comes into what is the right hemoglobin A1C control or target in those patients. I'm going to skip this slide and just going to go to the one next to it. Because the question comes, is it a strict control, intensive blood glucose control is the right answer, or is more conventional hemoglobin A1C control is the appropriate answer? And there's so many studies that looked into that, and there's so conflicting evidence what is the right thing to do in patients with chronic kidney disease. For example, in this study here, they looked into type 1 diabetes, intensive control in diabetes. And then also, yes, what they looked into in patients with intensive control, which is the solid line here, compared to the conventional diabetes therapy, the dotted line, patients actually do way better in terms of the intensive control group. And it same goes with the microalbuminuria as well. It is better in those patients compared to the other group. That's another study that looked at the same thing. There's a UK study that it shows that the evidence of microvascular complications, it actually goes lower with intensive glycemic control. And if you look into the limits and risk of the current treatment, intensive control in long-term diabetes, and this systematic analysis, it looks like that it actually shows, it doesn't show that much of a benefit in terms of intensive control versus a conventional control. When I say intensive control, taking something below the 7%, 6.4 to 6.9% of hemoglobin A1C. That's another study looking into the hemoglobin A1C and risk of all-cause mortality in patients with diabetes and chronic kidney disease stages 3 and 4. You can see that most of the benefit comes in when the hemoglobin A1C ranges around the 6.5 to 8%, and the higher obviously is the worst, and lower also didn't show that much of evidence to support a tighter control. Again, yes, the intensive control have a better survival free for all-cause mortality, but the problem is with that is the incidence of hypoglycemia. If you can see here, it is way higher in the intensive group versus the standard group. And I think that was the limitation of providing intensive glucose control. So what is the recommendation then? It's conflicting evidence. You're saying that it does improve the all-cause mortality, but at the same time, it has a lot of high hyperglycemia or hypoglycemia associated with it. Now, the recommendation for the ADA, it recommends that hemoglobin A1C for many non-pregnant adults is less than 7%. Now, the exception, less stringent A1C control goal less than 8% may be appropriate for patients with a history of severe hypoglycemia, limited life expectancy, advanced microvascular or macrovascular complications, so the complication already developed, and extensive comorbid conditions. And more stringent, less than 6.5, for selected individual patients, if this can be achieved without significant hypoglycemia. And it might include those with short duration of diabetes, type 2 diabetes, treated only with lifestyle modifications or metformin. So the goal here, or the message here is, individualized treatment for those specific patients. If the patients are able to tolerate, and there is a potential for a better and higher quality life of life, then maybe the 6.5% is the right answer. But in a patient with who developed all these complications, probably less than 8% would be a better target for those patients. So what is the agency going to use? So this is, again, atherosclerotic cardiovascular disease predominance, the GLP-1 receptor antagonist with proven cardiovascular benefit, or either the SGLT2I inhibitor with a proven cardiovascular benefit if eGFR is adequate. Now, if there is a heart failure or CKD predominates, then the SGLT2I with evidence of reducing heart failure, or if the SGLT2I are not tolerated or contraindicated, or if the eGFR is less than adequate, then GLP-1 with proven cardiovascular disease benefit. I'm going to go into details in a later slide about this. Now, there's some caveats about the glycemic, the A1C in chronic kidney disease. It's typically biased to the lower side, and there's so many factors associated with reduced RBC lifespan or increase in RBC turnover, and that because of the anemia associated with chronic kidney disease, erythrocyte stimulating agent use, iron deficiency, and hemolysis. All these things affects the reading of the hemoglobin C, and usually they're biased to the low. So it is recommended that self-monitoring of glucose is very important on those patients to give you a more accurate understanding or assessment of the A1C levels. Of course, the continuous glucose monitoring may complement or supplement the self-monitoring of blood glucose. Now, for the newer...
Yes. 2 minutes left, please. 2 minutes.
Okay. Well, I'll try to do my best here, but here for the newer glucose-lowering drugs like SGLT2 and the GLP-1 receptor antagonists, the risk of cardiovascular disease is reduced in patients with type 2 diabetes at higher cardiovascular disease. And you can see the answer is the SGLT2 inhibitor or GLP-1 receptor agonist reduce the cardiovascular disease and risk. So these are the outcomes for this statement. It prevents the development of microalbuminuria, reduce the eGFR, decrease the risk of end-stage disease and cardiovascular disease, and CKD benefits of SGLT2 inhibitors. All the studies that suggest that shows you the benefit of the treatment. This again, it shows the incidence of worsening nephropathy is actually better with this specific treatment. I'm going to skip this slide here. Let me just skip these slides and just go to the here. The balance of shift of glycemic goals with SGLT2 inhibitor. You also have to look at the lower risk of hypoglycemia while improving hyperglycemia, lower the risk of cardiovascular disease in patients with chronic kidney disease, and the lower risk of chronic kidney disease outcomes. And all these things has to be balanced and weighed against the benefit of the medications and the development of hypoglycemia on those patients. So I'm just going to conclude here. There is no specific treatment for diabetic nephropathy. Glycemic control, blood pressure control, blood glucose, lipid-lowering agents are the most important things that you can do to prevent the progression in those patients. Thank you very much, Dr. Muntasser.
Thank you very much. Great talk. Thank you very much, and for good tips for clinician. It is our pleasure also to introduce the second speaker, actually, and this is also congratulate for the scientific committee to bring another expertise in our Congress. The second speaker, Dr. Rayyan Al-Sharif. She is ophthalmologist and vitreoretinal specialist. She's working in ophthalmology department in King Abdulaziz. Hello, Aywa?
Yeah, no problem, no problem.
Can you hear me?
I sorry, I don't sound like a she, but
Sorry?
No, no problem.
No,
Go ahead.
sorry, Dr. Ryan, sorry, sorry, Dr. Rashif, sorry for that, sorry.
No,
Yeah,
not at all.
ophthalmologist, retinal specialist, and Department of Ophthalmology, King Abdulaziz University, Jeddah. Dr. Ryan, he's going to talk to us about multidisciplinary and integrating eye care in diabetes management. Thank you very much, Dr. Ryan. Thank you for coming, and you are very welcome.
Is this clear? طيب. Assalamu alaikum. Hello, everybody. As introduced thankfully by Dr. Muntasir, my name is Rayyan Al-Sharif. I'm a ophthalmology consultant. My primary expertise is in vitreoretinal medical and surgical conditions related to that area. I work as an assistant professor at King Abdulaziz, and I also work in private practice at a few institutions. Today, I'm going to talk about integrating eye care in the management of diabetes. Although I do believe that endocrinologists are doing a great job in the primary diagnosis and management of diabetes. However, this is a condition that has multiple comorbidities, and the management of it requires a multidisciplinary approach and a lot of teamwork. So as much as I admire the management done by endocrinologists, I do believe that they also have to play a primary role as if they're playmakers in a sport and start to pass the ball or shift the patient care towards different specialists, so the management can be delivered at a high quality. I've been most of my patients that I see are diabetics. Unfortunately, they present to me at different stages. So I think this presentation will try to deliver the stages of diabetic retinopathy, some of the studies that are related to diabetic retinopathy and diabetic management. What can we do to improve our care? How can endocrinologists be very valuable in the treatment and management of these cases? And some recommendations that maybe some of the endocrinologists or family physicians, I do not know the scope of the audience that are attending, but might find it valuable. So I'm going to start. These numbers might be a bit old. However, there has been since the 90s till 2017, there has actually been almost a fourfold increase in the prevalence of diabetes. The number of diabetics worldwide, I think, reaches over 400 million. And many patients are now in the pre-diabetic stage. Third of diabetic patients, maybe more in some countries, I do believe maybe more in Saudi Arabia, have never had an eye exam. They present at a very late stage. Third of the patients who actually would benefit from treatment that would halt the progression of visually disabling diabetic retinopathy, who would benefit from treatments like laser or intravitreal injections, have not been seen by an ophthalmologist for over 2 years. As you know, the prevalence of diabetes has been increasing along the years, and Saudi Arabia and Gulf countries and the Middle East in general is one of the areas that is heavily affected by this condition. Now I'll switch gears and go to the condition right away. So just like Dr. Abdullah Gashkari talked about the forms of nephropathy or the classification, also forms of retinopathy that might affect the vision go as following. There's something very important called macular edema. The macula is the central part of everybody's vision. It's where they see things clearly. If you are seeing the screen clearly right now, it means although you have a functioning eye, it also means that your macula is clear and clean and healthy. When you have diabetes at an advanced stage, you might have something called macular edema, and I'll show pictures of it in the next slides. And in that condition, your vision gets affected really badly. The second thing is that it goes in stages, just like in nephropathy, but it goes also from a non-proliferative to a proliferative stage. Proliferative means that the eye has become so ischemic that it actually produces new vessels. That's what proliferation means. And because those vessels are abnormal, they tend to do and cause complications. Now, the third kind of retinopathy is caused or formed by retinal capillary closure. And when that happens, you basically have ischemia, and that leads to the stages of diabetic retinopathy. This is a wide field picture of a retina. This is a healthy retina. You can see to your right side of the screen, there's a small circle. That's the optic nerve, and coming out of it are the vessels. These vessels have high integrity. You can see that otherwise the retina is orange. That's a retinal pigment epithelium. And the retina is a transparent structure right above that pigmented area. So it's made out of 10 layers. You cannot see it, but the vessels actually are through it. Now, this is a picture of a healthy retina. Now, just zooming in, this is a picture of a retina with diabetic retinopathy. You can see here right in the center, a lot, and around here, a lot of dot blot hemorrhages, we call them. Some are what we call nerve fiber layer hemorrhages or splinter hemorrhages here. And right in the center, you can see that there's a lot of exudates that are actually an exudation coming out of the vessels and forming right on the retina. This is where your macula is. Okay, so this is what I just talked about. And when a patient presents with this, they probably have been complaining from blurred and decreased vision. I'll just go back to the primary pathology in diabetic retinopathy. Starts off by vascular occlusion and leakage. Leakage causes the manifestation of macular edema. The retina starts to act like a sponge because it collects fluid, and vessel occlusion leads to ischemia. Now, the way that it's occluded because of the glycosylated hemoglobin is abnormal, and there's changes in the vessels. So you have basement membrane thickening, and then endothelial cell damage from these abnormally shaped hemoglobin formation that are in the RBC that actually start to scratch. I don't know if you saw my elbow, but it actually scratches the endothelium, and then it causes leakage. Then you have loss of pericytes, and the pericytes are very important to maintain the integrity of vessels. So when that happens, you have vascular leakage, and that leads to ischemia because not enough blood is reaching other cells. And then with time, with this damage, occlusion happens, and that's what actually leads to ischemia. This is a picture of a diabetic retinopathy. We're very fortunate in ophthalmology to actually see the pathology in our day-to-day practice. So this is an eye, as you can see, I just explained a while ago, you see hemorrhages here, some exudates. This is a more severe picture of diabetic retinopathy where you see massive exudation right in the retina. And this is something we see commonly in our clinics, unfortunately. Now, we actually have access to a very important technology called OCT, or optical coherence tomography. It basically cuts through the retina. I just told you it's 10 layers on the wall of the eye. This is it. This is when there's edema. So the retina should be flat on the wall of the eye, but here there's massive edema in the eye. Now, going to stages, this is, as you can see here, the optic nerve is right here, but then you see all these small vascular network branching right out of the optic nerve. And this is what we call proliferative diabetic retinopathy. This is a sign of severe diabetic retinopathy. and these patients are at the tip of an iceberg to develop new complications. When that happens, actually, instead of the retina being on the back of the eye, it starts to contract because these abnormal vessels with time fibrose and start to tug on the retina. And with time, because they start to become ischemic, they form fibrovascular membranes right on the retina. So it's actually as if something is grabbing into your retina like this and pulling it from where it should be, instead of it sticking to the wall of the eye. This is a very advanced level of diabetic retinopathy. This is when patients have reached a point where they have extreme visual loss. They might not even see right in front of them because of tractional retinal detachment, like I just described on my my scrub right now. You have pulling of the retinal structures. The retina is not where it's supposed to be, and you have what we call a tractional retinal detachment. These patients, unfortunately, have very bad prognosis, and the only treatment is surgery. And this is actually one of the most challenging surgeries to do in vitreoretina, unlike other conditions. And it takes hours to actually break up these very tight fibrovascular membranes to let the retina sit back where it is. Sometimes we achieve magnificent anatomical results with no improvement in vision. This is another wide field image of it. Just look how bad the retina is. I want to go back so you just see what a wide field retina looks like. And then I'll go to this slide and show you what a very bad retina with proliferative diabetic retinopathy and membranes that cause detachment. You can see here all these abnormal vascular networks and hemorrhage here and hemorrhage here. So these are the stages. We go from non-proliferative, and it goes from mild, moderate, severe, and then it reaches this level of proliferative that leads to two things: vitreous hemorrhage and tractional retinal detachment. Now, the primary thing that we need endocrinologists and everybody who's involved in the management of diabetics to refer to ophthalmologists and retina specialists is because we try to prevent vision loss. And that's a very important thing to every patient to improve their quality of life. With just an examination on a slit lamp, we can identify conditions and try to halt them by management. Now, retinopathy increases morbidity and mortality because visual loss usually happens with patients who have prolonged diabetic retinopathy, and it's associated with increased falls, more hip fractures, more likely causes of admission to the hospital, a fourfold increase in mortality because they do have other systemic conditions involved, or nephropathy, or cardiac issues, and it's also a cause of early death in type 1 diabetics. Now, what is the challenges that we face or barriers in the management of these patients? Well, public awareness. A lot of the patients who do have diabetes are not referred to ophthalmologists, and even if they're told, they are not urged and encouraged to see an ophthalmologist. Patient compliance is very difficult. I got to witness this firsthand while I'm practicing. A lot of patients don't have the motivation to follow up. They do not like to receive multiple treatments, which is unfortunately what we need to do in diabetic retinopathy. So when that is lost, many patients have their diabetic retinopathy being active in their eye. They're away from follow-up, and then they come when they only have severe changes or vision loss. The other thing is lack of funding for equipment, training, and education. That might not be an issue in Middle Eastern countries and mostly Saudi Arabia. However, that is an issue, especially in remote areas that lack specialized clinics. Also, collaboration between ophthalmologists and diabetologists, and I cannot stress that enough. We do have lack of engagement of providers of eye care. We lack a systemic process that helps us improve competency, whether that be with registers or data. And we do have access to treatment that remains a challenge because treatment of diabetic conditions in the eye is very expensive. The equipment is pricey. The medications are expensive. Patients need multiple treatments that I'll show in the next few slides. So that does remain a challenge. If patients are not insured or they are not eligible for government care or do not have access because of long waiting lists, that does present a challenge and a barrier to healthcare. So what is our retinopathy checklist? First of all, screening regularly. 2, delaying the onset and progression with glycemic and blood pressure control, and that happens by either the internist or the endocrinologist. And also treat established disease of the retina with laser photocoagulation or intraretinal injections that I'll show. Now, diabetic retinopathy is the most common cause of blindness among working age. I do not have numbers related to Saudi, but I do believe we have numbers that do affect the workforce because of diabetic retinopathy. Because not just patients with diabetes, you actually you sometimes have people or caregivers who are accompanying the patient, their sons, their brothers, or their parents, and that actually affects the workforce. So the most common cause of blindness in type 1 diabetics is developing proliferative retinopathy. They tend to have an aggressive disease. In type 2 diabetics, they mostly have a bit of both depending on their control, but mostly macular edema is what we see. So these patients are type 2 diabetics with prolonged diabetes, uncontrolled, and start to complain of visual decrease after a while. And then type 2 diabetics and non-insulin anti-hyperglycemic agents also present with a lesser chance of developing blindness. Now, what are risk factors for progression? And I think these are universal for most conditions that are affected by diabetes. However, when we see diabetic retinopathy, it's mostly related to longer duration of diabetes, elevated levels of HbA1c, systemic conditions like hypertension and dyslipidemia, anemia. Pregnancy is associated with rapid and massive progression of diabetic retinopathy. It's one of those conditions where we can see a patient who comes in with mild diabetic retinopathy when they are first pregnant, and then not even by the end of the second trimester, they might develop proliferative diabetic retinopathy. I have seen some patients who have developed very bad proliferative diabetic retinopathy in both eyes, to the point where abortion was discussed with the patient because of, or early delivery because of the risk of blindness versus completing the pregnancy. Proteinuria also is a risk factor, progression, and severe retinopathy itself. So what is our primary goal? Is to delay or halt the disease. And the best thing to do that is by, first of all, by the primary caregiver or the endocrinologist, by controlling blood sugar very well, controlling blood sugar and lipid-lowering therapy, and then referring to the ophthalmologist, as I said. There are multiple studies that are talking about how intensive treatment of and decrease of HbA1c levels can actually reduce the risk of microvascular complications, especially with retinopathy. So that study, one of the conclusions was that every 1% reduction in HbA1c was associated with 35% decrease of retinopathy and microvascular complications. The Wisconsin epidemiologic study of diabetic retinopathy was done in the early 2000s, also showed that tight glycemic control and blood pressure control may be beneficial to reduce the incidence of proliferative diabetic retinopathy, which is the enemy in what we want to prevent. The DCCT trial also in the early 90s showed that primary prevention with reducing, with improving glycemic control showed a significant effect in retinopathy in these patients. So what are treatments? I'll try to introduce you to some of the treatments that we do in a way of talking about how we integrate eye care and diabetes management. First of all, we have two methods or three methods of treatment. Two are office-based, one is surgical-based, sorry.
Dr. Ryan, 3 minutes, please.
Okay, okay, I'll try to rush this. First of all, we do laser. The goal of this is to kill most of the peripheral cells so we can preserve central vision. The other thing is giving intravitreal injections. These are very rapid in their effect. However, they're short-lived and they function for 1 month or 6 weeks, and then we need to give the patient another injection and then surgical intervention by surgery. I cannot stress the importance of screening. This is done primarily by the endocrinologist and by referring patients who have diabetes and then treating these patients early on, because a lot of these patients who do have vision loss would have benefited a lot with treatment that would have been done early on. Okay, so this is what laser looks like in the periphery. This is what an injection looks like. I know it looks scary and freaky, but it is actually a painless procedure with proper anesthesia, totally painless. This is how the medication is delivered into the eye to reduce what we call VEGF levels. And then this is surgery that we do for a very severe disease. I do believe telemedicine, especially now after Corona, has a promising role in protecting vision loss, especially in remote areas, in areas that are not sufficiently equipped or has a presence of specialists. This is a global condition. Many people will be impaired by this condition, especially in the future, if we do not treat and screen them regularly. My recommendations, I'll try to say these in 1 minute. Please tell me if I've exceeded the time. Screening and evaluation of retinopathy should be done annually. So please, if you are seeing any diabetic patient, ask them if they have seen an ophthalmologist. Recommendation number 2, the interval for follow-up should be tailored to the severity of retinopathy. Pregnant women with diabetes should be not just urged, you should walk them through to an ophthalmology clinic to make sure they are observed and monitored. Screening for diabetic retinopathy should only be done by experienced visual care professionals or by the use of retinal photography, like I showed you in a machine before. The results of retinopathy should be communicated to the entire team of care. Tight control of blood sugar is very important to prevent the onset and to delay the progression. What else? A treatment of blood sugar control, cardiac issues, and statin therapy should be instituted because they're very important and has been shown to reduce the progression of diabetic retinopathy. As I said, make sure a qualified ophthalmologist or a vitreoretinal specialist is seeing these patients, because ophthalmologists can miss these problems as well. And visually disabled people should be referred to low vision specialists. This is a job that we do and we take care of. So please make sure you screen these patients, make sure you follow up on their blood sugar control, make sure you refer them to ophthalmologists, make sure you urge them to continue treatment even if they are frustrated with it and if they seem to lack compliance. Sorry that I've exceeded the time, and thank you very much.
Thank you very much. Super talk and up to date. Thank you. The last and not the least presentation, actually, I would like to introduce, my pleasure to introduce the Dr. Mrs. Ahmed Lujain. She's baccalaureate degree in biochemical engineer and senior training and education specialist at Medtronic Diabetes for more than 5 years. She's conducted more than 50 workshops in Saudi Arabia and other Gulf countries, and many congress and advanced workshops in Saudi and overseas. Dr. Mrs. Lujain, she's going to talk to us about the power predictive arts in standalone CGM to improve diabetes management. Thank you very much. Thank you for coming. You are very welcome. Lujain, you are take care, please.
Thank you, Dr. Muntasser. Thank you for the introduction. Let me share my screen. So can you see my screen? So, Assalamu alaikum. Good evening, everyone. My name is Lujain Ahmed. I am training and education specialist at Medtronic Diabetes. And today I will be talking to you about the power of predictive alerts in standalone CGM to improve the diabetes management. The key objective of my presentation is to talk about and tackle the burden facing people with diabetes, importance of real-time CGM in managing day-to-day challenges, and then we would like to introduce Medtronic Personal CGM, Guardian Connect, how it works and system components, the power of predictive alerts to improve the diabetes management, Guardian Connect and remote monitoring, and then we would end up with the takeaway messages. Starting with the burden of diabetes, more in specific, the hypoglycemia. Type 1 diabetic patients have high prevalence of hypoglycemia. In a study that was done in 2015, it shows that 40% of people living with type 1 diabetes have hypoglycemia unawareness. In another trial that was done among people with type 1 diabetes controlled with HbA1c below 7.5%, the average daily time spent below target range was 14%. Not only in type 1 diabetes, in type 2 diabetic patients as well. As in a survey that was done in 2016, it shows that type 2 diabetic patients treated with insulin suffered from hypoglycemia unawareness, almost 9.8% of the people. In one study, observed patient in CGM showed that the frequency of observed via CGM showed that the frequency of unrecognized asymptomatic hypoglycemia was almost 74%. Studies shows as well that more than half of the people with diabetes are very worried about the risk of hypoglycemia. Not forgetting that it was actually proven that finger sticks can miss up to 78% of the highs and the lows. And in studies, it shows that 47% of people, 74% of people, actually alter their insulin doses for the fear of the recurring hypoglycemia. Even with the current technologies, patient burden is associated with a good A1C. A study that was published in the Diabetes Care in 2013 showed that patients who are depending on self-management blood glucose readings have to do at least 10 SMBGs per day in order to achieve a target HbA1c. Another study that was done in 2018 showed that patients who are dependent on flash glucose monitoring need to do at least 20 scans per day to achieve their target HbA1c. So the burden is real and the burden is huge to achieve a good target A1C for patients with diabetes. This brings us to the importance of real-time continuous glucose monitoring. As you can see here in this slide, these are the BG readings that was taken by the patient. And those BG readings are a single point in time readings where they do not give the physicians or the patient the full picture of the glycemic variability. It also depends on the frequency and the timing of the blood glucose readings. However, when we introduced the continuous glucose monitoring or added the continuous glucose monitoring system to the blood glucose readings that was done daily by the patient, now we can see the daily variability that are taking place between the blood glucose readings. We can identify the hypoglycemia episode and hyperglycemia episode that might happen during a day. So it actually gives patients and physicians a more complete picture. It also works as a behavioral modification and teaching tool in patients with diabetes to self-manage their day-to-day changes. As you can see here, for example, this is a patient using a continuous glucose monitor. So at around 9 a.m., this patient took a meal and it resulted in a severe hyperglycemia. So probably because the patient saw the effect of the meal on the glucose values, next time whenever they take this meal, they will alter the medication, they will change the type of the meal or the timing of the insulin injection. In another example that you can see here, where the patient did an exercise at around 4 p.m. Without the continuous glucose monitoring, patient might miss the hypoglycemia that took place 6 hours post the exercise. So probably again, next time when the patient do this certain exercise, they will take the preventive actions to let's say, reduce the hypoglycemia that might take place post this event. So patients with continuous glucose monitoring system will always observe and learn to modify their behavioral and day-to-day activities in order to achieve a better glycemic control. In a study that was done in 2017 for over 158 patient type 1 adults, it shows that patients who were using the standalone CGM over a period of 24 weeks of study, they showed a greater decrease in HbA1c in compared with those who were not using a continuous glucose monitor. So real-time CGM actually has great benefits for patients. To sum up, that in 2018, a study that was published in the Diabetes Care actually stated that the use of continuous glucose monitoring is now recognized as the standard of care for individuals with type 1 diabetes. This brings us to the introducing our personal real-time continuous glucose monitor, which is the Guardian Connect. What is Guardian Connect? Guardian Connect is a glucose monitoring system, and it's the only CGM system that will alert the patient 10 to 60 minutes before a high or a low, depending on the patient preferable settings. It will send the patient glucose values approximately every 5 minutes right on their smartphones. And it will allow them to share their alerts with family and friends to support and to increase the safety of patients. So what is our system components? So we need an in-light sensor, which is Medtronic sensor that is used with the Guardian Connect transmitter. It measures the glucose values in the interstitial fluid every 5 minutes, and it will be connected to the sensor, to the transmitter, sorry. The in-light sensor has to be changed every 6 days by the patient at home, where the Guardian Connect transmitter that will be connected to the in-light sensor will transmit the glucose values from the interstitial fluid to the Guardian Connect application on the patient's smartphone via Bluetooth. This device is rechargeable, and all of these data that are sent to the mobile application can be generated via the CareLink personal reports, which will gives us a set of easy reports for healthcare providers and for patients as well. So how does the system work? So the patient will be wearing the in-light glucose sensor, which will measure the glucose values in the interstitial fluid and transmit the data through the transmitter to the mobile application, where it will display the sensor glucose data, allow the entry of events for patient, and show the system status and alerts. All of these glucose data will be stored and linked in the CareLink personal account of the patient. Not only the glucose data, the event markers that has been entered by the patient as well, where later on, these data can be shared real time with the caregivers and care partners, or can allow an access for the healthcare providers to generate reports and do clinical decisions with the patients. So the patient will be using the sensor with the transmitter via Bluetooth Low Energy, the data every 5 minutes without needing to scan the sensor. It will be automatically sent and transmitted to the mobile application where the patient can view the glucose values. These data will be sent and stored in the CareLink cloud via mobile network or Wi-Fi, where it can be later on tracked remotely by the caregivers, or to allow an access to the data by the healthcare providers to generate reports and do therapy adjustments to the patient. How does the patient see the glucose values on the mobile application's home screen? So he will be able to see the last sensor glucose reading received by the transmitter, the rate of change arrows, and the rate of change arrows will tell the patient in the direction and the speed of the glucose values. So we don't only know the current glucose value, we know the direction and the speed of change as well. It will allow the patient to see the event they have entered during their day, which will help them to, as a teaching tool, to modify their glucose values according to the events that has been entered. Patient will also have an optional alert settings for high and for low settings as well, like alert on high, alert before the high, which are the predictive alerts, and the rise alert. Alert on low, alert before the low, and as well the fall alert. So these are optional alert settings where the patient will identify the limit and the type of the alert they would wish to receive to help them control their glucose values. This is Guardian Connect system real-life data, which shows the outcome for 258 patients using the Guardian Connect for over a year, who showed the time in range of 61%. And this result was sustainable over the long duration without compromising, as you could see here, the hypoglycemia. So Guardian Connect will help the patient to have a better time in range without compromising hypoglycemia. Whenever we talk about the Guardian Connect, we say that it provides the patients with self-management by having a 24/7 monitoring of the glucose levels and trends, where it will be displayed directly on their mobile devices, receive alerts predictively 10 to 60 minutes in advance of a high or a low, allow the healthcare provider to have an access to data, where the data of CGM data will be automatically uploaded to the curling professional, and they will be able to generate reports on glucose patterns of patients. Not forgetting the care partners and caregivers, which Guardian Connect will provide them with peace of mind now that they can remotely track the patient glucose real-time information on their own devices and receive optional SMS alerts for high-end glucose levels. So the key benefits of using Guardian Connect is predictive alerts to avoid hypoglycemia. Number 2, remote monitoring for caregivers to provide them with peace of mind. Access to data for healthcare provider to make better clinical decisions. Talking about the importance of the predictive alerts to avoid hypoglycemia. So predictive alerts, as you can see here, will help the patient to reduce the number of hypoglycemia and hyperglycemia exclusions by allowing them to take an action sooner before a hypoglycemia or a hyperglycemia actually happens. Real-world performance of Guardian Connect was analyzed through almost more than 2,000 patients, showed a result of 65% avoidance of low exclusions with predictive alerts, with the use of the predictive alerts, versus 36% without enabling the predictive alerts. So a 44% relevant difference, which is actually a significant difference. In addition to 44% lower and reduced high exclusions when using the high predictive alerts versus 11% high exclusions avoidance without using or without enabling the predictive alerts, with a 75% relevant difference as well. So enabling the predictive alert will help reduce the probability of high and low exclusions. Second, I'm going to talk about how does the remote monitoring for caregivers actually provide them with peace of mind. So as I said, the data that are shared by the patient or linked by the patient by the care link can be shared with the care partners. So the care partners can see exactly real-time sensor glucose values, exactly like the glucose that are seen by the patient, directly from an internet-connected device. It's via web app, so it's not an application, it's a web app, so it's a website where the care partners can log into and see exactly what the patients are seeing. And they can optionally choose to receive alerts when the patient are going to high or low to help with their safety. This is how the caregivers will monitor their loved ones, either via desktop or laptop. So this is how it's going to look like if they are monitoring them through the desktop or laptop. And this is via the mobile. So they can directly from any internet-enabled device monitor the patients using the care link, the Guardian Connect. So they will be able to see the sensor glucose values in addition to the sensor graph for the last 24 hours. This is an example of a message received to a caregiver, which will inform them about the alarm over the alert for the specific person who received this alarm and alert and the timing of the alarm and the alert. And these text messages, just to inform you, they do not require an internet connection for the phone of the caregiver as well. So it will provide them with peace of mind, as they know they have an access and they have the information about the situation of their loved ones at any time. The third point, where we talk about the access to data and providing healthcare provider the access to data to make better clinical decisions. So how does it work? So the patient will have the application where it will receive the glucose values from the Guardian Connect transmitter. These data, as we said, will have an automatic upload to the patient CareLink personal account. So the healthcare provider who are using the CareLink professional can link their software with the CareLink personal of the patient, where they will have an access to the data at any time. This will help the healthcare provider to have a virtual appointment with the patient and have collaborative, discussion over the phone or over any virtual way in order to improve, let's say, the glycemic profile of patient and do better clinical decisions. Under the current circumstances of COVID-19 pandemic, it was actually the recommendation stated that was published in 2020. They stated the importance of utilization the telemedicine to maintain the maximum self-containment. So now we can actually utilize the the Guardian Connect in order to have virtual clinics with the patients. Healthcare providers will have will be able to generate different type of CareLink reports that will analyze the patient glucose values, the event markers and the effect on the glucose reports, and of course some behavioral reports to show the patient performance as well. Let me show you an example of a real case for patient on Guardian Connect. So this is the first 2 weeks on Guardian Connect, and this is one of the CareLink reports for this patient. As you can see here, this is the gray area which represents the target. And here, as you can see, is the average glucose values over the period of download. So healthcare provider, actually, after seeing this, did some modification to the patient treatment. And after 2 weeks later, after flying back at home, we re-downloaded the report for the patient. And as you can see here, that the average glucose values were highly improved. So it helped the patient to improve their glycemic profile and help the healthcare provider as well to make better clinical decisions to have a better outcome. This is another example. This is the first week on Guardian Connect. As you can see that the average glucose values were way above the target, where after 3 months of using the Guardian Connect, there was a significant improvement in the glucose values for the patient. So we at Medtronic, we actually provide the patient with support and services, of course. So because Guardian Connect is a personal use for patients, we have actually developed an online training program for the usage of the Guardian Connect system. Not only will inform the patient about the Guardian Connect and the technicality of the Guardian Connect, it will give them as well information about what is continuous glucose monitoring, how to manage their diabetes, what is the difference between the sensor glucose values and blood glucose values, and other topics. So this can be accessed just directly by accessing this website, where the patient, they have an interactive training program on Guardian Connect and other topic as well. To ensure the patient success journey, we have a program that was developed by our customer support services, which called the Start Right program. The Start Right program is a free 3 months onboarding program that provides personalized support for your patient once they start on Guardian Connect. So it's really informative and it's really helpful to ensure that the patient will have a successful journey by using the Guardian Connect as well. We support our patient technically and troubleshooting their, let's say, whatever they will face with Guardian Connect. If they have any information they would like to know, any let's say, training they would like to attend, so they can always contact our customer support services either via the email, logging into our website, or directly contacting them through the free toll number that we have. So to summarize, people with diabetes are still facing daily challenges to maintain the good glucose control, especially when it comes to hypoglycemia. Real-time CGM provides people with diabetes with more complete picture to make better daily glucose control. And now, CGM is actually recognized as the standard of care for individuals with type 1 diabetes. Predictive alerts can and be are a powerful tool to improve the diabetes management for patients with diabetes. And by using the Guardian Connect, Predictive Alert will protect patients against hypoglycemia by alerting them 10 to 60 minutes before its occurrence. The remote monitoring will provide peace of mind for caregivers by allowing them to have a real-time access to the data at any time. And healthcare provider will be able to make better clinical decisions by having access to data, which will facilitate the virtual clinic and telemedicine. Thank you so much.
Thank you very much, Lujain. Thank you very much. Great talk. Actually, we are waiting for the question actually to start. Actually, already we're on time now. All right. Okay. Thank you very much. Okay, we have two questions actually for each doctor. We'll start by Dr. Reem Al-Amoudi. The first question: management of hyperglycemia in end-stage renal disease patient on hemodialysis. I think this is wrong. It's not Dr. Reem. This is for Dr. Abdullah, I think, or because it's written for Dr. Reem. Anyhow, management of hyperglycemia in end-stage renal patient on hemodialysis. How to differentiate between DKA and hyperesmolar non-ketotic. I think again could be. Let us talk. Dr. Reem, can you answer this question? It's not related to your topic, but how in patient. Sorry? Okay, Dr. Reem, okay, I'll start the question. The question actually not related to your topic, but they said if you have a patient of hyperglycemic anemia and end-stage renal disease with hemodialysis, how to differentiate between DKA and hyperesmolar non-ketotic? How to calculate serum osmolarity, but mainly how if the patient already in metabolic acidosis, okay, due to chronic kidney disease or hemodialysis.
Yes.
So how to differentiate this for DKA?
I mean, sure, if you want me to answer, we can talk about it, although as I said, it's totally unrelated. But anyhow, diagnosing DKA in patients with renal failure is extremely, extremely difficult, as you said, because of the baseline acidosis. And I mean, generally what we go with is if there's any acute changes, change in the anion gap, a sudden increase that cannot be explained otherwise, apart from the sudden onset hyperglycemia, and change, in the clinical status that supports diagnosis. But this is generally how you go for it. And what's even more difficult than diagnosing it is treating, because we know that the main way of treating DKA is fluids, which is something that you cannot give liberally in patients who already are, on dialysis, or patients with end-stage renal failure. And here, you probably depend more on giving the insulin rather than, giving too much fluids. If the patient is due for dialysis by itself is very helpful in, elevating the situation and correcting.
Thank you very much. The second question: the effect of statin and lipid-lowering drug in non-alcoholic fatty liver disease.
So there's many studies on statins and lipid-lowering drugs, and they do show a lot of, a good effect in and they are helpful in reducing the substrate. However, the substrate itself and de novo lipogenesis and the lipogenesis itself. However, the studies that looked into changes in the reversing fibrosis or the biopsy-related change and resolution have not shown them to be that effective. However, they are still recommended, but not alone or not as a mode of action to resolve the steatosis or the NASH, but rather as a helpful agent that will add on to the effect of the other agents used to treat NASH.
So thank you very, very much. Thank you for good response. Dr. Abdullah, you are in mode actually. Can you change? Yes, thank you. The question for you, Dr. Abdullah, what is the preferred equation to calculate GFR?
Well, there isn't any specific or preferred equation for the GFR. You can use whatever you want to calculate the GFR as long as you continue monitoring or using the same equation for that particular patient to follow up for follow-up. If you're talking about the creatinine, and the other thing you can do, this is test to may have a little bit better estimation for the GFR. But the short answer is whatever you want to use, just stick to one so you can monitor the patient with that GFR.
Very good. We like short answer. Very good. Okay, the second question, Dr. Abdullah, what is the indication for dialysis in patients with diabetic nephropathy in general?
Okay, so there's a lot of evidence looking into should we start early or should I delay the dialysis as much as possible? And that goes with any diagnosis of stage renal disease, whether it's diabetic nephropathy or not. So the indication of dialysis are the same everywhere else with any diagnosis. Volume overload that cannot control medically, hyperkalemia cannot manage medically, acidosis cannot be managed medically, and the uremic symptoms, with the patient having nausea, vomiting, and itchy, and you cannot manage it medically. So it doesn't matter what creatinine level the patient come in with. I always tell my patients, you are the one who's going to tell me whether you want to start dialysis or not. And that was based on the symptoms that the patient present with. So there isn't any one thing that I look for to start dialysis. It's just a constellation of things the patient comes in, helping to make that decision with the patient.
That's good. Actually, it's individualized rather than any figure or creatinine. Thank you very much. Dr. Rian, any rule for prophylactic laser therapy in early retinopathy? Prophylactic?
Only if it's at a stage of severe non-proliferative diabetic retinopathy and you are aware that the patient has uncontrolled HbA1c levels and might fail to compliance. The benefit of laser is that it's lifelong. So if you are worried about compliance and you know the patient has high levels of HbA1c in a severe NPDR, although there are specific criteria that were defined by a few studies, we actually tend to manage at an earlier stage depending on the case. But yes, we do it sometimes earlier if we feel that the patient's non-compliant or if the blood sugar control is very bad.
Excellent response. The second question, Dr. Rian, how can we diagnose DN in hyperfiltration stage?
Sorry?
No, this is a question, I think...
this is for me, probably.
No, this is not for you. This is for Dr. Abdullah. Sorry, Dr. Rian.
Yeah.
They put it under your name. How Dr. Abdullah, how can you diagnose diabetic nephropathy in hyperfiltration stage?
Yeah, so you're off the hook now for this one. Okay, so I'm not sure what the question means, but if you're talking about the early stages of diabetic nephropathy when there is hyperfiltration, it's actually when you do, at the onset of diabetes, you can see the GFR higher than the average of a normal individual. If one of the slides I showed, the average normal GFR is about 115, whereas in those patients actually goes up to 133. So at this stage, I know that the diabetes actually have this functional changes in the kidney, and that is the early stage before the structural changes in the kidney. So it's just a GFR number.
Yeah, that's good actually, because this is a rule of the screening rather than...
Exactly.
Thank you very much, Lujane. So the first question how can patient access the online connect portal? The access of the portal.
Okay, so if they would like to access the data directly, they can log into our website. So there's a website specific for patient to access their data, if this is what they mean by the question. If they mean the training modules and the training program, again, from the Medtronic Diabetes website through the Guardian Connect tab.
Very good. And the last question, talking about money. Everybody talking about the money now. So how is cost? Is that a question for you or that go to marketing?
So probably they would need to contact our customer support services to know more about the details of the cost and the availability of the product in different regions in Saudi. So the numbers that I have shared, they can contact them for more details regarding the price.
All right. Okay. I think most likely this is the end of our session, and we are in time. This is great. There is a question, I think, for Dr. Abdullah. What is the blood pressure target in patients with diabetic nephropathy?
Okay, so that is something that I was not able to cover in the presentation. There is a lot of evidence. Should you target lower blood pressure in the less than 120/75, or should you have a little bit less stringent blood pressure control, 140/80? Again, it's individualized. If the patient is able to tolerate a lower blood pressure, then that's what exactly we're going to look for and I'm going to aim for. If the patient is not going to be tolerate a lower blood pressure, because especially elderly, right, you're going to have this postural hypotensions and falls and all these things, then that is the patient that probably I'm going to be less stringent when it comes to blood pressure control. But also I want to highlight and echo Dr. Rayyan's point at the beginning. Referral to the right specialty early on in the disease makes a huge difference for those patients. When it comes to chronic kidney disease or blood pressure monitoring, I love to see them early on. It makes it way easy for me to manage those patients on the long run, even if they develop end-stage disease. And that is a really good message that Dr. Rayyan mentioned earlier.
That's great, and thank you very much. I would like to thank all the speakers. Sorry, anybody have any comment or anything? Thank you very much for all the speaker, the audience, of course, and the scientific committee for a tremendous presentation. And sorry, the last not the least, actually, من لا يشكر الناس لا يشكر الله. الشكر كل الشكر للشركة المنظمة الفيرتشوال meeting. They are doing great job, actually. Thank you very much. وإن شاء الله we'll see you next year face to face. Thank you very much. مع السلامة.